everyone, this is Olivia Marks, here to share my review of an article entitled Peri-Epiphyseal and Overuse Injuries in Adolescent Athletes. Skeletally immature athletes and injuries. Young athletes can suffer all of the same injuries adults can, but because of the open growth plates, there are additional sites for injury as compared to a mature skeleton. These overuse injuries are often insidious, slowly sneaking up on the young athlete, but then hitting them like an avalanche. The physis, or the growth plate, is a layer of cartilage cells between the epiphysis, or the end of the bone, and the diaphysis, or the shaft of the bone. These cells are more active and prone to injury during growth spurts of adolescence. An immature skeleton refers to a skeleton in which the bones have unfused or non-ossified growth plates. Throughout the body, different physes ossify at different ages. There are also differences in skeletal maturation between the male and female skeleton, and even between athletes in different sports. For example, gymnasts and ballet dancers often have more delayed skeletal maturity than other athletes, and will thus have growth plate injuries appear at a different age. The term growth plate injury may also encompass injuries of the bone portion next to the physis. According to the American Academy of Orthopedic Surgeons, Salter-Harris is a classification system for growth plate fractures. So when you hear Salter-Harris fracture, that refers to a fracture of the growth plate or the surrounding area. Radial epiphysitis. This injury is most common in gymnasts and other athletes who bear weight on their wrists. The athlete will experience a gradual onset of wrist pain. Radiographs usually show sclerosis or hardening on both sides of the growth plate. If this injury is not treated appropriately, permanent bone changes may occur. This epiphysitis of the distal radius is the slowest healing of all the physeal injuries. Immobilization is the most common treatment for it, usually in a cast to reduce the pressure or ability for the athlete to be non-compliant by seeing how it feels, returning to weight bearing on the wrist too early. Let's move on to the elbow. Elbow overuse injuries often occur due to the repetitive microtrauma from throwing or weight bearing through the long axis of the bones. Medial epicondyle apophysitis is one injury in a collection sometimes referred to as Little Leaguer's elbow. The epiphyseal cartilage of the medial epicondyle is vulnerable to throwing trauma. Rest for 4 to 6 weeks with a gradual return to throwing is usually the treatment course for medial epicondyle apophysitis. Osteochondritis dissecans is when an alteration of the blood flow to the subchondral space causes a lesion in the bone. If this lesion is not treated, it can collapse. Treatment for osteochondritis dissecans varies depending on the severity of the lesion. Osteochondrosis of the capitellum, or Panner's disease, on the other hand, is usually benign with a self-limiting course that can resolve itself with rest and modified activity. Olecranon apophysitis occurs commonly in gymnasts and throwers. Typical symptoms include pain over the olecranon and pain with resisted elbow extension. If this injury is not treated quickly enough, the olecranon process can fragment. Rest appears to be the best treatment for all of these elbow injuries. Now we can look at proximal humeral epiphysitis, or the little leaguer's shoulder. This injury includes osteochondritis, epiphysitis, or epiphysealocyst to the proximal humeral epiphysis. Complications, if this goes untreated, are premature closure of the physis, so the athlete's humerus will not be able to grow to its full size, or a Salter-Harris fracture. Treatment for this includes rest. The athlete must stop throwing until their range of motion is pain-free and their radiographs return to normal. This process can take up to a year. Compliance is most likely a huge issue in this. Let's look at some injuries that can occur to a skeletally immature spine. Spondylolysis is a stress fracture of the pars interarticularis, which is the portion of the vertebra between the superior facet and the inferior facet on the same side of one vertebra. The athlete will present with pain in the paraspinal area. Spondylolysis may progress to spondylolisthesis, which is where the body of one vertebra displaces anteriorly over the one below. If caught early enough, spondylolysis can be treated with rest and bracing. Spinous process epiphysitis may mimic the symptoms of spondylolysis, but is usually non-progressive and self-limiting. The athlete will feel tenderness exclusively at spinous process and lower back pain with hyperextension, but little or no pain with forward or lateral flexion, which are both more common pains in spondylolysis. Bracing and avoiding hyperextension for 4 to 6 weeks is typically recommended for spinous process epiphysitis treatment. Radiographs are usually unremarkable for both these injuries, but accurate diagnosis is extremely important for determining whether or not the athlete can continue to train and compete. Moving further down the body, let's look at some pelvic overuse injuries. Iliac epiphysitis occurs with a similar mechanism to Osgood-Schlatters disease, which I will discuss in the next slide. It is a repetitive traction injury to tendon attachment sites. It could be that it occurs because of a subclinical stress fracture at the unfused iliac apophysis, or it could be an inflammatory reaction to the repetitive traction. Iliac spine avulsion can occur if iliac epiphysitis goes untreated. This requires surgical repair. Ischial epiphysitis is often misdiagnosed as hamstring bursitis or tendinitis. Noncompliance can lead to avulsion of the ischial tuberosity. Moving down to the knee, we have tibial tuberosity epiphysitis, or Osgood-Schlatters disease. This is the most common overuse injury in adolescent athletes. Osgood-Schlatters disease occurs when tensile microtrauma from repeated forced knee extension pulls on the tibial tuberosity. If it goes long enough, the tibial tuberosity can separate or fragment away from the tibia. Treatment for Osgood-Schlatters disease involves 4 to 6 weeks of modified activity, ice, and immobilization, followed by a stretching and strengthening program. Compliance with treatment may minimize the risk of tuberosity enlargement and bony ossicles forming within the insertion of the patellar tendon. Moving down to the heel, we see epiphysitis of the os calcis, or Sever's disease. The calcaneal apophysis becomes thickened and fragmented. There can also be concurrent metaphyseal stress fractures. 61% of cases of Sever's disease are bilateral. This injury may be slow to resolve because of young athletes' noncompliance, but because stress injuries of the foot may quickly progress to more serious problems, it is important that we encourage athletes to be compliant. Treatment for Sever's disease includes gastroc and soleus stretching, dorsiflexion strengthening, discontinuation of running, and wearing a shock-absorbing heel cup. Because of young athletes' noncompliance, casting may help resolve symptoms the fastest, usually in about 4 weeks. Finally, we have epiphysitis of the proximal fifth metatarsal, or Isolin's disease. This occurs due to microtrauma from the pull of peroneus brevis tendon. The athlete may present with lateral midfoot pain during running, jumping, or cutting maneuvers. Pressure from shoes may also exacerbate symptoms. As with Sever's disease, casting may be the quickest resolution. After 4 weeks of immobilization, the athlete usually must do a peroneal strengthening and stretching program. Let's look at the quality of the research. The purpose of the article was to analyze publications about epiphyseal and overuse injuries, to increase recognition of these injuries, and to provide treatment recommendations. The article did a pretty good job at providing a broad overview of these injuries, although some of the sections of the article were slightly scattered in their presentation of the different injuries. How is this relevant to us as future physical therapist assistants? The authors made a huge emphasis in their conclusion that not all overuse injuries directly affect the growth plate. Most of these injuries are to the portions of the bone that surround the growth plate. There was also emphasis that a delayed diagnosis leads to a longer healing process, but that an earlier diagnosis leads to a quicker healing process and can help prevent season or career-ending injuries. There was also emphasis throughout the article that young athletes are going to be non-compliant. They don't want to rest. It's important for us to encourage the athletes, their parents, and their coaches that rest is going to provide the fastest healing process for these athletes, and that jumping back in the game too early will not be good for this athlete in the long run. Thank you for listening to my presentation. In the description below, I will put my email address, and I will also be sending out a copy of my PowerPoint and the article that I used. Feel free to email me with any questions. Thanks again!